in most cases, you avoid that upfront risk, but what you lose is hope. You lose hope of something better. And
Right.
that is actually a really important thing for people. We all need hope. We all need something to look forward to say things can get better. Things aren't all downhill from here.
Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals, with me, Kathryn Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While a NICU parent's scars are not as visible, those parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals, like you, better understand, support, and nurture the entire NICU family. Howdy, everybody. If you can believe it, y'all are about to hear our very last NICU Heroes podcast episode of the year. It has been such an amazing year. I have really enjoyed the wisdom, the varied guests that we've had, and the topics that we have covered. It has been such an educational and inspiring year, and we're going to end it with an exceptional guest. We're focusing today on spinal deformities in children. There are many, and there are many courses of treatment, lots of things to understand. It's a big organ with a lot of intricacies. And so I found a neurosurgeon who has an absolutely fascinating path as to how he got into neurosurgery, how he got into medicine, and then how he's serving his patients today. So my hope is that you listen to this. One, that you're going to understand the spine better. You're going to understand the treatment options. But I'm really grateful that in this particular interview, you're going to hear a lot of hope. So as you stand at the bedside with your NICU families and your NICU patients, my desire today is that as you listen to this and you receive great information and great perspective, is that you're going to be able to give those families maybe a lot of hope that they didn't have before. So I'm excited that my guest today is Dr. Michael Bohl. He's a board certified neurosurgeon at Carolina Neurosurgery and Spine Associates, and he provides adult and pediatric neurosurgical care. His clinical special interests include treating adult and pediatric scoliosis, degenerative spinal disorders, spinal malformations, spinal fusion, spinal tumors, and spinal trauma. Dr. Bohl has a diverse educational background, including completing an orthopedic spinal deformity fellowship at Virginia Mason Medical Center in Seattle, Washington. He attended residency at Barrow Neurological Institute in Phoenix, Arizona, and then he graduated medical school at the University of Michigan Medical School in Ann Arbor. Dr. Bohl is also a U.S. Marine Corps veteran. He served 2 combat deployments to Iraq and was involved in humanitarian aid missions in East Africa in the early 2000s. Dr. Bohl is married and has 3 children, and he and his family enjoy living in the Carolinas. I would too. And all of the outdoor activities that provides, like hiking, fishing, and exploring local parks. Outside of caring for patients, Dr. Bohl's hobbies include woodworking, running, and spending time with his family. I know that you're going to be inspired by this conversation. So without further ado, let's get to it. Well, I am excited to have the expert in the room, Dr. Bohl. Thanks for being here today.
My pleasure. Thank you for having me.
Well, you have a fascinating story. So before we talk a little bit about spines and spinal deformity and kids, I think I'd love to visit with you a little bit about your stint that you spent in the military, particularly in the Marines, and how that sort of led you to medicine. So let's start there. Tell us about your time as a Marine.
Yeah, I'd love to. So coming out of high school, I wasn't real sure what I wanted to do. Like many 18, 19-year-old
Right.
young men, I was a little bit unsure, a little bit lost. I knew I wanted to be in some position of service, but wasn't really sure what that meant, and just knew that I wasn't real excited about school at that point. And so I enlisted in the Marine Corps. I left for boot camp at 4 a.m. on September 11th of 2001. So from almost the from almost the first moment, the world was different when I got in. During my time in the Marine Corps, I was a reconnaissance Marine, and I did 2 deployments, both to Iraq, and those were very formative formative experiences for me. It confirmed that for me that I wanted to be of service in some kind to people and serve others, but didn't want to do it that way necessarily. I felt that what we were doing was very important, but what I really found very meaningful to me were the humanitarian aid missions we did, working in orphanages and then any of the kind of medical mission type things that we assisted with. Those were kind of really what fascinated me. And so that was kind of where the initial thought of going back to college and pursuing some kind of healthcare career started. I was on a humanitarian aid trip in Africa where I kind of first started thinking in those lines. And so during my time in the Marine Corps, I started teaching myself Swahili because I was kind of putting together this plan to go back to East Africa when I got out of the military to work in a health clinic there and figure out if healthcare was really what I wanted to do, if working with sick people was something that actually was a good career path for me. And so when I got out, that's exactly what I did. I spent a good amount of time there. I quickly picked up Swahili because I'd been studying it on my own and speaking to myself for a couple of years in Swahili. Actually, I kept learning it on a second deployment to Iraq, and one night on when I was on patrol at night, I had this book, how to teach yourself Swahili, and an officer walked by and just looked at the book and looked at me and said, "They're all speaking Arabic, dummy." So I thought that was pretty funny. I didn't even attempt to explain what I was doing.
Right.
So
Right. Too complicated.
too long of a story. And so when I got out, I worked as a nurse's aide in Tanzania for a while and loved it. Just felt like I really found something I was passionate about, and so eventually went back to school and got an opportunity in East Africa to work with a surgeon from New Zealand for a while. That was my first experience with surgery, and that really excited me. That definitely got my attention. And so that was kind of how all of that started.
Well, I'm smiling because I'm thinking neurosurgery is highly specialized, a lot of school, and a lot of high pressure, oftentimes complicated cases. And you're
Hmm.
telling me that you were a Marine and then you did humanitarian aid and taught your house Swahili. And so, I mean, it all sort of tracks, Dr. Bohl, that neurosurgery sort of feels like the place that you might end up. But of all the surgeries, I mean, there are many parts to the body. What was it that intrigued you so much about neurosurgery?
Yeah, I think that was just it. Is that it? For one thing, the people there. I went to medical school at the University of Michigan, and I knew I wanted to be a surgeon, and I worked as a transplant perfusionist my first couple of years as a medical student. And I also shadowed with a bunch of surgeons just trying to figure out kind of where did I fit. And the neurosurgeons just seemed to be, to me, to be the best fit. And those cases also seemed to be the best fit. Maybe you're exactly right. Maybe that's just why I landed there. But it just really seemed, it seemed like, I think at one point I told my wife in medical school that I didn't really want a career where every day kind of felt the same. I kind of wanted to come home feeling like we battled very challenging things and came home very, very successful, or we did our best kind of situation, and I think neurosurgery definitely is that, because I think you're right. the issues, the diseases, the things we see in neurosurgery are very threatening to people's sense of self, their sense of identity, their functionality, their personality, their ability to do simple things like get out of bed in the morning. And so it's a really big deal to people, and that struck a chord with me. I just felt like my heart was in that kind of work for sure.
Well, speaking from experience, our interaction with our son's neurosurgeon, he was in many ways like you, highly driven, but also really a super fan of what it is that he studied and the work that he did. And I think that's what made him such a good neurosurgeon. Is not only did he love the area of the body that he was focused on, but he also really loved his patients, and that was apparent to us. So I appreciate the passion there. I think it might be helpful, Dr. Bohl, for people to understand a little bit of some of the terminology that you and I might be talking about a little bit today. So,
Yeah.
neurosurgeon, orthopedic spine surgeon, what's the difference between the two?
Yeah, that's a good question. So it really has to do with which residency you do. Now, to
Okay.
become a doctor, a practicing doctor in the U.S., you have to finish 4 years of medical school. After 4 years of medical school, you're trained broadly in medicine, but you aren't qualified to see or treat patients for anything. In order to do that, you need to do a residency. And that's where you really learn how to become an independent practitioner in some kind of field. And so neurosurgeons do a 7 year neurosurgery residency, where for those 7 years, we're treating everything that can go wrong with the brain, the spine, and all the nerves in our bodies. And so,
So small, really small things. Wonderful.
exactly.
Okay. Okay.
Orthopedic surgeons do a 5 year orthopedic surgery residency, and they're focused on the whole body's skeletal system. So anything that can go wrong with bones and joints, like a broken arm, like a worn out hip, and then of course cancers and things that happen in bones. They're becoming experts at bones and joints. And the spine is it exists in both of those worlds, right? It's a whole lot of bones and joints, but it's also your spinal cord and nerves running through all of those bones
Yes.
and joints. And so both neurosurgeons and orthopedic spine surgeons treat spinal disease. They just both come at it kind of with very different backgrounds and training. And so there are certain diseases that traditionally were always treated by one or the other. But fortunately, what I have seen in the last 15 years has been a progression away from these sharp lines between the two, which used to exist decades ago. Nowadays, people like me are becoming more common, where I did a neurosurgery residency, but then I did a fellowship. Now, fellowship is an extra year or two of subspecialty training, where you say, okay, I'm a neurosurgeon, but I'm going to focus extra hard on this one aspect of it.
Okay.
And so my fellowship, I spent a year with an orthopedic surgeon doing spine deformity, so that I could kind of get both skill sets, both mindsets when it comes to spine disease.
So for the layperson, like if I have a kid who has a spinal condition, how do
Mhm.
I sort of differentiate or figure out which specialist might be the right fit for my kid and what their condition is?
Yeah, I think that both are fine. Both are very good. The key thing, though, is that you want to find somebody who specializes in what it is you have. You know, if
Yeah.
if if you have a spinal tumor, you want to find somebody who really focuses on spinal tumors. If you have
Okay.
scoliosis, you want to find somebody who really focuses on that. That's probably the best way to sort it out. But so long as you're seeing somebody who's comfortable diagnosing and treating what you have and does a lot of it, it's it's probably it's probably fine, either way. Obviously, obviously, I have my biases, but I
Sure.
I kind of live in both worlds, so need to be careful of.
No, I think I think it's helpful when you talk about looking at what they're fellowship trained in or where most of their patients come from. We've
Yeah.
had tethered cord and scoliosis in our home, and so it does give us a sense of like which doctor or which surgeon might be the best fit for our family, and also for this particular kid and their particular, ailment that we're trying to figure out. So I think that's really good advice. So I don't want to use these two words interchangeably because I don't think that you can, but you can tell me. So scoliosis, spinal deformity, is that accurate, not accurate? How would you describe that?
Yeah, that's a great question and a common one. The way I would think about it is spinal deformity is an umbrella term that
Okay.
encompasses any and all problems with the shape of somebody's spine. Scoliosis is a specific type of spinal deformity where when you look at somebody's spine from the front, there's an S shape or C shaped or a double S. So when you look at somebody's spine from the front, it should be straight. But if it's doing something like that, that's scoliosis. You can
Okay.
also have spinal deformities in other planes and in other types of deformities. So there are a lot of different kinds of deformities, spine deformities, other than scoliosis. And so spinal deformity is kind of a catch-all term for there's a problem with the shape of somebody's spine.
That makes sense. So, what are some of I know that you operate, as a matter of fact, I think that was also today that you were doing that. So, I know
Yeah.
that you operate and treat lots of different patients for different sorts of spinal deformities. What are the things that you do the most?
Yeah, it's a good question. I think the things that I see the most in clinic, and this is representative of what occurs most in our general population, are adult spinal deformities. And then because I'm a neurosurgeon working in a large neurosurgery practice, the pediatric spinal deformities I see more often they're in kids who have other neurosurgical diseases. And so I also see a good amount of that, a good amount of various different kinds of pediatric spinal deformity. And so, and then because of my practice, because I'm generally doing if spine deformity operations are bigger surgeries, and so because of that, I also end up seeing a lot of patients who need extensive revision surgery, meaning they've had a bunch
Mm.
of surgeries before and they need it redone, or they need something fixed, or they need it extended, or something that's very complex. Because of my subspecialty in my practice, I end up seeing a lot of unusual or difficult or complex things. And so those types of things also very commonly come through my practice, which as a surgeon is people either see that as good or bad. I really enjoy that. Those patients need help too, and just because they've
Right.
seen a bunch of other people or because they have a difficult or unusual problem doesn't mean it can't be treated. And so I very much enjoy being a place where folks who have had a hard time for one reason or the other can find a home. And even if I'm not going to offer surgery, I still follow them and help them get to the right place eventually. Because there are a lot of people out there who just feel kind of passed around, kind of
Yeah.
not quite getting an answer they want, or not quite clear what the path forward is. And that's okay. It's not uncommon. Some people have difficult, unusual, or complex things, and it's nice to be able to be a home or a resource for those folks, especially if you're commonly seeing uncommon things. Does that make sense?
No, it does. I mean, it absolutely tracks as you kind of share a little bit about your path to neurosurgery and your love, I guess, of finding things that are complicated and figuring out how to make them uncomplicated so that kids can have, or your patients can have, a life that's full of movement, but also of less of pain. So I'm curious, Dr. Bohl, when you have a patient who comes in, I'm not going to say that other surgeries are less maybe invasive or less traumatic, but sometimes when people hear spine, they get really nervous because of what it's connected to and how it's the base for a lot of the things that we do as humans. So, how do you walk patients through? Okay, so this is the surgery that we're going to do while also helping I think them understand like what might life look like post surgery, because it's a tender place to operate. And I know when me and my son both went in for spinal surgery, even though I knew all the things at least that I felt like we could get our heads around, it was still a little nerve-wracking walking into
Yeah.
that surgical OR.
No, it's scary, and for good
Yeah,
reason. Your spine it's a really big deal to trust somebody with your spine, and as a surgeon, it's I take that very seriously, and it's a huge honor. And so we need to, it's important for us to recognize that, not only in this kind of forum, but also with all of our patients. I
right.
to just say I understand what it is, the amount of trust you're placing in me, and it's a really big deal to me, right?
Yeah,
And so that's one thing, is just being able to acknowledge where somebody is, acknowledge that this is scary, and that you understand that can go a long way. I think the best way to answer that question is just to say that it's when you're facing a really difficult decision, especially when it comes to something like your health and whether or not to have a big surgery or a surgery that sounds scary for whatever reason. It's best to think of it in terms of the risks and benefits of having the surgery, but also in terms of the risks and benefits of not having the surgery, because
right.
you're going to do one or the other.
Yeah, you have to
um,
choose.
not making a choice is making a choice, right? You're choosing not to have
Sure.
the surgery. And so nobody has a crystal ball, but there are some things that we feel that we understand pretty well about the natural history of certain diseases, meaning what happens with certain diseases if you just leave it alone. And there are a lot of spine conditions out there where the natural history is pretty terrible. It's a progressive decline in your quality of life, a progressive decline in your mobility, progressive worsening of pain. And for a lot of people, they're already well along that path by the time they come and see us. And so
Mhm.
it's just important to have a discussion in those terms, which is, the options are do all the non-surgical things we can try, all the physical therapy and injections and braces and anything and everything that's at least reasonable to try it. But if you're doing those things and they make it worse or don't help at all, and life is just getting worse and worse and worse, there comes a time where we need to make a decision. Is a surgery may be the lowest risk thing you can do,
Right.
when you compare it to the risk of not having surgery. But there is a difference that makes it scarier. The difference is that if you take an adult spine deformity, for example, that's painful and progressively worsening, the risk that that person ends up debilitated over 10 years may be very, very high. It may be 90+%. But their risk on any one given day of becoming debilitated is very low. It's just the cumulative risk over 10 years
Right.
stacked up, and it's actually very, very high. It's, some studies would say it's quite probable. It's almost certain. With surgery, if you look at the 10-year risk, the risk that it looks much better. Surgery can avoid that natural history. It can return your quality of life, but you do take this much bigger risk up front that one day of surgery, right?
Yeah.
And so total risk might be less with surgery, and in most cases it likely is. You just take a whole bunch of it up front. And
Right.
if we get through it just fine, which usually we do,
Yeah.
your risk goes back down to normal, your quality of life should improve, and you move on, and continue life with a better quality of life. Without surgery, there's in most cases you avoid that upfront risk, but what you lose is hope. You lose hope of something better. And
Right.
that is actually a really important thing for people. We all need hope. We all need something to look forward to say things can get better. Things aren't all downhill from here.
That's really beautifully said. I know of all the surgeries that our son had, I never asked more questions than I did with our neurosurgeon. I had 2 pages of questions. I think I was just trying to understand what are the risks, but also what are the benefits. And then, then there's that leap of faith that you have to take. There's no guarantees, but we knew that quality of life was going to be better if we moved forward. And another family may have chosen something differently. But I was grateful that we had a patient surgeon who sat down in that chair and answered all those questions. So a lot of babies present sometimes in the neonatal intensive care unit with a tethered spinal cord. So, Dr.
Mhm.
Bohl, how and ours was a little tricky to see initially. So, what are some things that you might look for if you suspect, I think there may be a tethered cord situation? And maybe start with what is a tethered cord?
Yeah, yeah. So the spinal cord usually ends somewhere around L1 or L2, which is the top of your lumbar spine. It's kind of right where the bottom of your rib cage is. And, in what we would consider typical anatomy, there's a small fibrous tether that comes off the bottom of the spinal cord and attaches to the sacrum. And in some cases, that ligament or that piece of tissue that connects the bottom of the cord to the sacrum, it becomes thickened, it becomes fatty. That ligament is called the filum terminale. And so one common thing you'll hear is a fatty filum. If it fills with fat, it becomes very stiff and rigid. And so as a baby grows, if that ligament isn't stretchy like it should be, it stretches the spinal cord out because the ligament won't stretch, the cord will stretch.
Okay.
And nerves, especially the spinal cord, don't like being stretched. There are other ways that somebody can have a tethered spinal cord, like if there's a tumor in the spine that is stuck to the cord and the wall of the spinal canal, that can also cause spinal cord tethering. And there are people who've had tumors taken out of their spinal column or out of their spinal cord who then develop scarring and effectively develop a tethered spinal cord in that situation. But kind of the classic pediatric tethered spinal cord, it's usually a problem with that ligament, the filum terminale, becoming thickened or too fatty. And sometimes it presents real early in life, but sometimes it presents too when somebody has their growth curve during their juvenile years. Some little kid does just fine until they start getting a lot taller, and then suddenly they start developing a whole bunch of symptoms, and that's usually one of the first things we check in those cases.
So, are there some physical things that you might look for? Like, we'll use a baby as an example. Would there be some physical things that you might say, "Oh, that might make you question"? Oh, we suspect there might be a tethered cord there. Maybe we'll do an MRI to confirm. Like,
Yeah,
what would you look for?
especially in newborn babies, especially you want to look for signs of spina bifida, so sacral dimpling, a hairy spot on the back, or in the worst cases, something called a meningocele, where there's actually an opening in their back. Those are clear indications to check to screen a baby for any spinal cord issue, including spinal cord tethering at that point. If there is not a spina bifida and the child is neurologically normal, oftentimes there isn't an indication to check. And if there is a tethered spinal cord, it might not present itself until they start growing at a rate that the filum can't keep up, and then they'll start developing symptoms. So in those cases, we see things like a child who was previously walking normally, now toe walking. They can't get their heels down, or they develop bowel and bladder issues. Bowel and bladder incontinence can also develop. Weakness, spasticity, and gait issues are a real common one.
This podcast is produced by Hand to Hold, a national nonprofit, but we're more than simply a podcast. Hand to Hold is here to support your NICU in two ways. One, you can refer your NICU parents to us for support, or two, you can bring dedicated Hand to Hold support to your NICU, either in person or virtually. Our support consists of one-to-one group and educational resources, including our family-focused podcast, NICU Babies Parent Support. For more information, visit handtohold.org and click on NICU Professionals. If a child has tethered cord, are they at higher risk for other, or spina bifida, are they at a higher risk for other spinal deformities? Is that sort of the gateway? Like if you have one, you open yourself to a higher risk for others?
Yeah, that's correct. If you have one, you should get screened for other things. If there's one congenital issue, congenital meaning it's something that you're born with, something you developed with, then there could potentially be others. With tethered spinal cord, spina bifida, those types of issues, kids are at risk for certain types of spinal deformity, including scoliosis, but usually it's in that case, it would be something like neuromuscular scoliosis, where it's more so a curve developing because there's some issue with the communication between nerves and muscles, and the muscles aren't quite able to support the spine as it grows.
Spine is fascinating, almost as fascinating as the brain. I know that's why you put those together, but I I'm curious when you mention a little bit about. I want to talk about spina bifida before we get to scoliosis. So some parents may hear, or their child is diagnosed with spina bifida, and maybe it's not a case where it's automatically assumed. Looking at the child, they may find out later. Dr. Bohl, how do you counsel those patients to give them an idea of like what quality of life might be for their
Yeah.
children? Because I know 30 years ago when someone was diagnosed with spina bifida, our reaction to that was very different than a diagnosis from today. So how do you help parents sort of wrap their minds around this is what could be possible for your child?
Yeah. It varies widely, and so the best indicator are things like, is the spinal canal open? Is there a meningocele or a myelomeningocele at birth? That definitely puts people in a different category, and they can still those children can still have very, very normal lives, but most likely they will have some kind of neurological deficit that they grow up with. And sometimes it's very mild, and it's something that is very manageable. Sometimes it's very severe and effectively leads to no neurological function below whatever that level is. So we see a full range. And I see a lot of just completely asymptomatic adults who have very mild spina bifida and never knew about it, and so it ranges a lot. There are a lot of people out there leading normal lives with no spine issues who, if you look on a CT scan, you can see clearly things didn't quite close in the back, but that's it, and it's never created an issue, probably never will. And so we see the full spectrum from totally asymptomatic to, impacting all function below that level type severity. And so the biggest predictor for that would be how it presents initially, most likely.
Okay.
Yeah.
Well, I hope that gives people some hope, because I think sometimes we hear about a spinal deformity and we assume a certain thing about not only that condition, but about what the quality of life may be like. And then we also forget to factor in what technology or what advances may happen in medicine over the course of time of having that particular deformity that may improve or stabilize quality of life. So I hope that gives people a little bit of hope as to don't just
Yeah.
take the diagnosis just for what it is on paper, that there's a lot of variables there.
100% agree. There's hope is a very important thing. And it's hard to know initially where somebody's going to land. The important thing is to just, like we said at the beginning, just find somebody who specializes in that, find somebody who sees a lot of that, and establish a relationship,
Yeah. Well, I think that's the case for a lot of things in life.
Yeah.
I want to switch over a little bit to scoliosis and talk about, because I know that when diagnoses started happening like in the 70s and 80s versus fast forward into the 2020s. Big difference in how it's treated, how you operate. So give people an idea. I know you talked a little bit about what scoliosis is. How do you determine if a child has scoliosis? And then sort of what are the steps to whether you start with monitoring, then bracing, then surgery, sort of what are the markers for saying, okay, now we're going to intervene and do this thing?
Yeah, absolutely. So you're right. So decades ago, scoliosis was something that every school age child got screened for in school.
Mhm.
I'm sure you remember that.
I do.
I was screened for several years, where all the boys and all the girls would file through the locker room or something and take your shirt
Yep.
off and bend forward and see if there's a rib hump. now
Yes.
Nowadays, the pediatricians take care of that on their well child visits. So there's a difference there in terms of how we screen kids for it now. The most common type of scoliosis is adolescent idiopathic scoliosis. And so there's some big words in there worth unpacking. Adolescent just means that it typically presents between the ages of 10 and 18, which is what, that medically the defined adolescent period is. Idiopathic scoliosis, basically what that word idiopathic means is that there's no known underlying cause of the scoliosis, meaning there isn't some kind of neurological disorder, there isn't a spine tumor or a tethered cord or a history of spinal cord injury or a congenital defect. There isn't something like that we can see and find that we would say, yes, that is causing the scoliosis. It doesn't mean we don't have any kind of understanding about why it happens. We do understand. We think we understand a little bit about why it happens. For one thing, it appears to us as though one of the things that happens is, for some reason, the one half of the spine, usually the left half, stopped growing before the right half, and so that develops this curve. It's not always that sidedness, but usually it is. And we think that because the anatomy on the left side is much smaller than the anatomy on the right in those cases, the bony anatomy.
Fascinating. Okay.
From the natural history studies that were done over the course of decades, we know that there are a few things that really matter when it comes to this most common type of scoliosis. One is, how big is the curve? Curves that are little are less worrisome than curves that are big. Once curves reach about 45 to 50 degrees in severity, we know that they're likely going to keep getting worse and worse even after somebody finishes growing. And that's an important thing, because that also usually tends to be when we start considering surgery. Curves, spinal curves, scoliosis, it gets worse most rapidly during kids' rapid growth phase on the growth curve. So as they hit their growth spurt, their curve starts getting worse most quickly. If they finish growing and they have a curve that's less than 25 degrees, there's almost no chance that that curve will become an issue for them later in life. If it's more than 45, 50 degrees, there's a very, very high chance that that curve is going to just keep getting worse, even though they're done growing. And so in those cases, we typically start discussing surgery because we want to avoid that natural history. We want to avoid them being a 40-year-old adult with instead of a 50-degree curve, a 90-degree curve, or some debilitating kind of condition. For kids who fall in the 25 to 45 or 50-degree range, most likely it won't become an issue, but there are some exceptions. And as somebody who sees both adults and children, I do see a lot of those patients. I see 20 and 30-year-olds who last remember having a 40-degree curve when they were 16, 17 years old and didn't need to do anything about it appropriately. but now they're 35 and they've had 3 or 4 kids and they have a 60-degree curve and their back hurts, and so that isn't the most common outcome, but it can happen. And that's okay too. We can still fix it at that point in time. But the 25 to 45 degree range, there's a little less certainty about what will happen. Most likely nothing will happen and they'll do just fine. But there are some exceptions to that.
Feel like you just looked at my notes because you just described me. So, that's fascinating. So, what advances have been made in surgery? I mean, when I had my surgery, which was 18 years ago, I know that there have been massive strides in how you treat scoliosis, particularly from a surgical standpoint. So, maybe walk us through what you used to do and what you do now.
Yeah, no, you're right. It's very different now. For one thing, many, many decades ago, in the 70s and 80s, we didn't have the hardware that we have now. It was Harrington rods,
Mhm.
kind of rods that you would put in somebody's spine and then kind of telescope or push out to try and prop the inside of a curve up and squeeze the outside of the curve. And that was a great advancement for that time, but they certainly came with their own problems. Prior to that, the way a lot of spine deformities were fixed was to just expose somebody's spine, take a bunch of bone out of their hips, and just lay that bone over the curve, and then put them in a body cast or on bed rest for 3 to 6 months, and just let the spine fuse in that shape, so that it doesn't get worse. And so the Harrington rods, the hooks and those types of things, that was a big advance. Since that time, we now have what are called pedicle screws that we can put in at each level and do what's called segmental fixation. So we can basically grab a hold of each single level of the spine and get much better curve corrections. Now, there was obviously, anytime there's a new technology, there's a learning curve. Pedicle screws really came into use in the 90s. And so we're at a point now where the safety around using pedicle screws, especially in more complex conditions like scoliosis, is safer now than it ever has been in the past. The risk of paralysis with a spinal deformity correction used to be, decades ago, was probably 1 in 300 or 400.
Wow.
Nowadays, it's probably more like 1 in 4,000, something like that. So it's much, much safer than it ever has been. The other big advancement are in things like just how we manage people, how we proceed through these potentially long and complex surgeries, how we manage them medically, what we use in terms of the anesthesia and nerve monitoring, which is a system that helps us keep track of how well the brain, spinal cord, and nerves are functioning.
Right.
When I first started doing these cases and as a resident, the amount of time it took and the amount of blood that was lost was, factors of 10 more than what it is now. And it's not that there was anything wrong with what was being done before. It's just we've learned so much over time. And fortunately, this is a field where things really truly do keep getting better and better with each passing year. There's still potentially long, complex surgeries, and there are still those cases where there's high blood loss. But there are also now, more commonly, there are cases with very little blood loss that takes 3 to 4 hours. A case I did today was a spine deformity surgery that we lost 200 milliliters of blood, which is very little. If you donate a unit to the Red Cross, they typically take 500 from you. So it's less than half of what you'd lose if you were donating. And it took 3 or 4 hours. I remember cases like that taking 8, 9, 10 hours a long time ago. So it's just, we're getting better and better and better at it over time. It's better now than it ever has been. And I'm optimistic and hopeful that 10 years from now we'll be saying the same thing about where we're at now. And
where you are now.
they were saying that about the
Right.
2000s. So that's a good thing, actually. We are
Yeah.
truly getting significantly better with each passing decade, for sure.
So it's almost like less invasive surgery, less blood loss, greater outcome, greater quality of
Yeah,
life.
yes to all of those, except the invasiveness part. We do still, there are what I would call quote unquote minimally invasive options, and those are great. But when it comes to a lot of the more complex spinal deformities, that is still an open surgery, and I
Yeah.
don't think that doing it closed or doing it minimally invasive, I don't think that we're there yet on that actually being the same. Hopefully it gets to the point where it's better, but it's not even the same. It's just worse at this point.
Right.
And a lot of people define minimally invasive differently, and so there will be some differing opinion out there on this, obviously. But fixing somebody's scoliosis through a tube or without actually looking at the spine, or with, that's not something that is really being done yet. In certain patients there are options like spinal cord, this is going to be confusing because this is actually what it's called, but something called spinal cord tethering. Doesn't
It's
mean
okay.
that we go in and put a bunch of fat in the ligament attaching the cord or stretch the
Right.
cord. It's different. But that's basically a treatment usually for scoliosis, where we go in through the side, and instead of putting screws and rods in, we put screws in through the side of the spine, and then a tether, like a, for lack of a better word, like a thick shoelace, and just tighten the shoelace to try and pull somebody's curve, if
That
it's
makes
if it's a long
sense.
hair, to try and pull their curve back,
Mhm.
which will still give them normal range of motion. There are certain specific patients where that option would be good for,
Right.
but the standard of care is still to do an open surgery, meaning an incision down the back where you expose the spine, put the screws and rods in, and that's not minimally invasive. But
Sure.
it is the gold standard still, and it is far better than it ever was before. So all of the rest of those things definitely still apply.
Well, personal experience says, yes, I can confirm that what you're saying is true, and we've lived through that. I'm curious because this idea that the spine is a complicated, complex organ, which
Mhm.
means that sometimes the interventions or the surgeries that you do tend to be a lot of money, or that you have to have access to care. Dr. Bull, how do you personally, and how does your practice, how do you address this like disparity of care of people that may have access to someone who specializes in the spine, or that maybe they don't have the transportation or they don't have the education levels? How do you make sure that those kids, those families get the intervention that they need to have beautiful, thriving lives too?
That's a great question, and that's something that we as a nation definitely need to tackle when it comes to how our healthcare systems are built. I think that the what I do and can do personally is to continue to have a practice where, when I'm seeing somebody in clinic, I don't I don't need access to their insurance status or anything like that. I'm going to make a recommendation regardless of that. But obviously, that can be a barrier to people even getting to me in the first place. And so, if I know that there's somebody trying to get to me and having a hard time, what I will do personally is reach out to them, try and be flexible in terms of office visit times, give them a wider range where they can arrive, or do telephone visits, a visit like what you and I are doing right now, where we just discuss over the phone, or even a video conference, so that we can, meet each other face to face, and I can look at somebody at least. There are things like that I'm always happy to do and happy to troubleshoot with somebody. but it is a real challenge, for
Yeah.
some people. They just don't, for some kids especially, they just don't have the ability to have regular routine care. And these are complex things. This is not just seeing your pediatrician and then moving on your
Yeah.
way. This requires a hospital stay and regular follow-up and imaging studies, MRI, CT scan. There's a lot to it. And so those problems with our healthcare system really become apparent with these kinds of complex disorders. So that's a great question. I wish I had a clear cut solution, but the things that we can all do personally are to just, one, recognize when we're dealing with somebody having a hard time. It doesn't always present as somebody telling you that they have a hard time. Sometimes it presents as somebody acting out because that must be a really hard thing to go through. And, how we all deal with that emotionally is going to vary. And so one is recognizing it and then having sympathy towards it and whatever, offering to meet them where they're at in terms of what they can do so that this child can get the care they need and get the best chance that they can have for a good quality of life.
Right. I mean, and I know that some of those families are also dealing with, maybe they have a child who's wheelchair bound, and then the spinal deformity becomes worse because
Yeah.
of their current situation. And so it's sometimes layered, that they have multiple organs that they're working through with various specialists. And so they all start to add up, and it's this guessing game as to which one is the most critical and which one can we address. And
Yeah.
then, can we live with this? And then how do we move forward with that? I know it's a challenge for a lot of families, but I'm grateful. I know that there are lots of charities, and both throughout the hospital and other places, that people can address, hey, we need the surgery. What's possible for us to do? What's out there? And, well, what the severity is.
Yeah, definitely. That's a great way too, is to, if you're dealing with that kind of situation, is to put people in touch with
Yeah.
any and all resources that might help them. Yeah.
Well, I always like to ask this question because it's fascinating to me how much medicine can change in just a short amount of time. So, Dr. Bohl, if you had to dream a little bit, like maybe the next 10 to 15 years in spinal deformity care and just the progress that can be made, like, what is your
Mm.
hope for how you can treat patients and give them a better quality of life in the work that you do?
Yeah, I mean, I think that if we were to, just kind of look into the future and see what would be great
Yeah.
is, some kind of functional, for lack of a better word, spine replacement, some kind of
Mhm.
device that basically performs all the functions of the spine. So in kids or adults who just have a really difficult problem that isn't going to be fixable with something minimally invasive, something that is lower risk, but for somebody who's been through umpteen surgeries, or their spine just isn't capable of supporting them, being able to give them sort of a fresh start, so to speak. Now, that's not something that we have currently the technology to do, but that is something that I think would be pretty great.
Oh, I like it when people dream a little bit. I think it's
Yeah,
good for us, a good exercise to say what's possible and how can I be a part of that, and then, get you excited, or maybe re-excited about what it is in the work that you do.
that's mostly inspired by patients. I have a lot of patients who tell me, "God, I just need a new one."
Well, I think we can all think of an organ that we're like, "Man, if I could just get a new one of those, I would be, like A plus plus."
I'd love to be able to say, "Well, we can offer you a new one," but
Right, let me pull out the catalog and
yeah,
you can
exactly.
choose. Yeah,
What color would you like?
exactly, exactly. I'm gonna ask you one last question because, you mentioned it at the beginning, and it's kinda stuck with me about this hope portion. If there is maybe a NICU professional who has a patient and they've just been diagnosed with some sort of spinal deformity,
Mhm.
what is something that professional can do at the bedside or with that family to give them some hope about what may be in store for their patient?
Yeah, yeah, I would just say that spinal deformity, although it's a serious problem, it's a very treatable problem, and that In most cases, it's not an emergency. Obviously, if there's an open spinal canal, a myelomeningocele or a meningocele, that needs to be addressed right away. But otherwise, typically not an emergency, typically something where you can sit down with a specialist and talk through it and get the right imaging studies ordered and have some time to process it, but also just emphasize that these things, although very serious for sure, are treatable, and that in many cases people go on to have very, very good, very normal quality of life despite having a spine deformity. In most cases, in the most common kind, people most often go on and lead a perfectly normal life, and so it is a potentially kind of quote unquote curable thing. Now that there will be spine screws and hardware there, but that generally we consider that outcome better than a slow progressive loss of your quality of life and having a severe deformity by the time you hit middle age kind of situation. That's an avoidable future for sure.
Yeah. No, I'm glad that you said that. Sometimes I think when we find ourselves in the neonatal intensive care unit, everything feels critical and emergent and must be addressed now. So it's comforting to know that in most cases that you have a little bit of time to breathe, a lot of time to ask questions and figure out what's the condition that we're dealing with, what are our options, and then what's the
Mhm.
best course forward, so that you have a little bit of time to take a moment before you have to maybe go into the OR or do something else. So, Dr. Bohl,
Yeah,
I know that you're a busy man, so thank you so much for taking the time to visit with us today.
it's my pleasure. Thank you. It's an honor to be here, and thank you for inviting me on.
Thanks, y'all, so much for listening. That was a fantastic conversation. I hope that you'll do me a favor. If you love today's episode, please share it with a friend. You can also review over on Apple Podcast or Spotify or wherever it is that you listen to podcasts. You can also give us a listen and a watch over on YouTube. It's how we reach more NICU professionals. Today's podcast episode is sponsored by Reckitt Mead Johnson, whose mission is to nourish the world's children for the best start in life. For more than a century, they have led the way in developing safe, high-quality, innovative nutrition products and continue to push the boundaries of nutritional knowledge with consistent, strong investments in scientific exploration.